The American Nurses Association, ANA, has established evidence-based guidelines that a restraint-free environment is considered the standard of care. The ANA encourages the reduction of patient restraints and seclusion in all healthcare settings. Restraining or secluding patients is viewed as contrary to the goals and ethical traditions of nursing because it violates the fundamental patient rights of autonomy and dignity. However, the ANA also recognizes there are times when there is no viable option other than restraints to keep a patient safe, such as during an acute psychotic episode when patient and staff safety are in jeopardy due to aggression or assault. The ANA also states that restraints may be justified in some patients with severe dementia or delirium when they are at risk for serious injuries, such as a hip fracture due to falling. The Joint Commission defines a chemical restraint as a drug used to manage a patient's behavior, restrict the patient's freedom of movement, or impair the patient's ability to appropriately interact with their surroundings that is not standard treatment or dosage for the patient's condition. It is important to note that the definition states the medication is not standard treatment or dosage for the patient's condition. In those instances where restraint, seclusion, or therapeutic holding is determined to be clinically appropriate and adequately justified, registered nurses who possess the necessary knowledge and skills to effectively manage the situation must be actively involved in the assessment, implementation, and evaluation of the selected emergency measure, adhering to federal regulations and the standards of the Joint Commission regarding appropriate use of restraints and seclusion. Nursing documentation is vital when restraints are applied and includes information such as patient behavior necessitating the restraint, alternatives to restraints that were attempted, the type of restraint that were attempted, the type of restraint used, the time it was applied, the location of the restraint, and patient education regarding the restraint. Frequent monitoring according to agency guidelines and provision of basic needs, food, fluids, and toileting must also be documented. Any healthcare facility that accepts Medicare and Medicaid reimbursement must follow federal guidelines for the use of restraints. These guidelines include the following. When a restraint is the only viable option, it must be discontinued at the earliest possible time. Orders for the use of seclusion or restraint can never be written as a standing order or PRN as needed. The treating physician must be consulted as soon as possible if the restraint or seclusion is not ordered by the patient's treating physician. A physician or licensed independent practitioner must see and evaluate the need for the restraint or seclusion within 1 hour after the initiation. The patient in seclusion or restraints must be routinely monitored according to agency policy. Generally, the best practice for physical restraints is continuous visual monitoring or visual checks at least every 15 minutes. Some agencies require a 1-to-1 patient sitter when restraints are applied. Physical restraints should be removed every 1 to 2 hours for range of motion exercise and skin checks. Each written order for a physical restraint or seclusion is limited to 4 hours for adults, 2 hours for children and adolescents ages 9 to 17, or 1 hour for patients under 9. The original order may only be renewed in accordance with these limits for up to a total of 24 hours. After the original order expires, a physician or licensed independent practitioner, if allowed under state law, must see and assess the patient before issuing a new order. In addition to continually monitoring the site of a physical restraint for skin issues, a physical restraint should only be secured to the bed with a quick release knot in case of emergency.